Uterine prolapse. Uterine prolapse is a fairly common condition, especially among the elderly women. Downward displacement of uterus from its normal position is called prolapse of uterus. Uterus is held in its normal position by its supports. Damage to the muscles, ligaments, and of the uterus results in prolapse of uterus. Because of the close relationship with vaginal walls, prolapse of uterus is associated with prolapse of anterior and posterior walls of the vagina. Supports of the uterus. There are three levels of support. Level 1. Uterosacral and cardinal ligaments support the uterus and the vaginal vault. The cervix remains at or just above the level of ischial spines. Level 2. Pelvic fascia, paracarpus, which connect the vagina to the white line on the lateral pelvic wall through the arcus tendinous fascia of the pelvis. This includes pubocervical fascia anteriorly, rectovaginal fascia and septum posteriorly. Level 3 include levator ani muscle, which supports the lower one-third of vagina. Levator muscle forms a platform against which the pelvic organs, uterus and upper vagina get compressed during straining. Damage to level 1 support causes uterine descent, enterocele and vault descent. Damage to level 2 support causes cystocele and rectocele. Damage to level 3 supports cause urethrocele, gaping introitus and deficient perineum. Etiology of prolapse uterus. Weakness or injury to the normal supports of uterus result in uterovaginal prolapse. In most cases, damage to the support occurs as a result of mismanaged childbirth. However, a congenital defect or weakness of supports of uterus can result in prolapse of uterus and vagina. Withdrawal of hormonal support, especially estrogen following menopause, is an important factor for the onset of symptoms of prolapse. Rarely, pelvic trauma or nerve damage to the pelvis can result in prolapse uterus. Raised intra-abdominal pressure, chronic constipation, chronic obstructive airway disease also play a role in development of pelvic organ prolapse. Mismanaged childbirth, unsupervised or wrong practices during labor or puerperium can predispose a woman to the development of uterine prolapse. Prolonged bearing down efforts in the first stage of labor before the full dilatation of cervix results in undue straining or tears of Meccan rods and uterosacral ligaments. Similarly, application of forceps before the full dilatation of cervix results in tears in cervix and Meccan rod ligament, with subsequent risk of uterine prolapse. Birth of big size baby can also predispose to prolapse uterus by damaging cervix and the supporting ligaments. Following a childbirth, poor rehabilitation in puerperium, early resumption of physical activity, lifting of heavy weights can predispose women to prolapse uterus. Menopause. Menopause is characterized by declining levels of estrogen. All the supports of uterus are under the effect of estrogen during the reproductive years. Declining levels of estrogen after menopause result in loss of tone of the muscular supports and relaxation of ligamentous supports of the uterus. These changes predispose the woman to uterine prolapse in presence of pre-existing weakness in the supports of uterus. The etiology include menopause, congenital weakness, birth injuries like prolonged labor, perineal tear, pudendal nerve injury, operative vaginal delivery, multiparity, big baby. Other causes are raised intra-abdominal pressure, chronic bronchitis. The classification of prolapse. Uterovaginal prolapse system. Anterior vaginal wall defects in upper two-thirds cause cystocele. Lower one-third defects cause urethrocele. Both together include cystourethrocoele. Posterior vaginal wall defect. Upper one-third causes enterocele, the pouch of Douglas hernia. Lower two-thirds cause rectocele. Uterine descent. Descent of the cervix in the vagina. Descent of cervix up to the introitus and descent of cervix outside the introitus. Precedentia means entire uterus is outside the introitus. Cystocele. Prolapse of the upper two-thirds of the anterior vaginal wall is called cystocele. The bladder is supported by the pubocervical fascia, which extends laterally into the arcus tendinous and fuses with the levator ani muscle below. The urethra is supported by the posterior urethral ligament, which is fixed to the pubic bone. Prolapse of the uterus. If uterus prolapses, there is always some associated descent of the anterior vaginal wall. It is customary to describe 3 degrees of prolapse of the uterus. In the first degree, cervix descends into the vagina. The second degree, cervix descends to the level of introitus. In third degree, cervix protrude outside the vaginal orifice. In procedentia, whole of the uterus protrudes outside the vagina, bringing it with it both the anterior and posterior vaginal wall. And it may be possible to feel the loops of small intestine in the pouch of Douglas. In most cases, vaginal portion of the cervix is high, and in uterine prolapse of third degree, the epithelium covering the cervix is often thickened. Keratinization occurs. Prolapse of the posterior vaginal wall. Prolapse of middle third of posterior vaginal wall is called rectocele. In rectocele, the rectum protrudes with the posterior vaginal wall. The tissues which normally intervene between the posterior vaginal wall and the rectum may have been damaged by obstetric injury, and the vagina and the rectum may become adhered by the scar tissue. Prolapse of upper one third of vaginal wall is called enterocele. This portion lies in relation to the pouch of Douglas. Decubitus ulcer. Keratinization and pigmentation of the vaginal mucosa as well as ulceration of the prolapsed tissue are caused by friction, congestion, circulatory changes in the dependent part of the prolapse. Reduction of the prolapse with daily packing of tampons soaked in glycerin, acryflavin solution or betadine in the vagina helps in the healing of ulcer within a week or two. Decubitus ulcer needs to be differentiated from cancer of the cervix. Apart from cytology and biopsy, other distinguishing features are that decubitus ulcer shows a clean edge and heals on reposition with vaginal packing. In rare cases, carcinoma develops at the site of decubitus ulcer or when a ring pessary is left in situ for a long period of time. Elongation of cervix. As the supravaginal portion of the cervix is well supported by the mechanoid ligament, but the vaginal portion of the cervix prolapses with the vagina, the supravaginal portion gets stretched and elongated. This usually happens with the second degree and the third degree prolapse of the uterus. In procedentia, the entire uterus slides with the cervix and hence cervix retains its normal length. Obstruction of the urinary tract. A large cystocele may cause kinking of the urethra, leading to the hypertrophy of bladder wall and trabeculation. The kinking of distal ureters in procedentia can lead to hydroureter and hydronephrosis if the prolapse is not surgically corrected. Urinary tract infection is not uncommon as residual urine remains in the bladder in the large cystocele. Incarceration of the prolapse is encountered in rare cases due to edema, congestion, and the prolapse become irreducible. POPQ system. Staging of the POPQ. In stage 0, no demonstrable prolapse is seen. Stage 1, all the points are below -1. Stage 2, lowest point within 1 centimeter of the hymen, that is between -2 and -1 and +1. Stage 3, lowest point is greater than 1 centimeter below the hymen, but not complete prolapse. Stage 4 is complete prolapse with its lowest point equal to total vaginal length -2. Symptoms of prolapse. The patients mostly complain of something descending in the vagina or something protruding outside the vagina. The prolapse is aggravated by straining and coughing and by heavy work, whereas rising from the bed in the morning, the physical signs of prolapse are the least. Often patient states that prolapse reduces by itself when she lies down. If there is large prolapse, external swelling may cause inconvenience to her during walking or carrying out her day-to-day routine activities. Even in mild degree, patients are conscious of a sense of weakness and lack of support around the perineum. Towards the end of the day, the patient may complain of vague mid-sacral discomfort, backache, which are relieved by rest. This symptom is most logically explained as a strain on the uterosacral ligament. Some women suffer from bearing down feeling above the pubes. In most cases of prolapse, there is some degree of vaginal discharge. The discharge may emanate from a chronically inflamed lacerated cervix, but may also be caused by the relaxation of the vaginal orifice, which allows bacteria to invade the vagina and produce mild degree of vaginitis. A friction or decubitus ulcer is an obvious cause of discharge and bleeding. Menstrual cycles are usually normal. One of the important symptoms associated with prolapse uterus is urinary complaint in the form of incomplete evacuation of bladder or frequency of micturition. However, the most frequent is stress incontinence of urine. In this condition, there is involuntary escape of the little amount of urine during any act associated with raised intra-abdominal pressure, such as coughing, sneezing, change of posture, lifting heavy weight. This imperfect control of micturition caused by lack of support to the sphincter of urethra. Frequency of micturition is also an important symptom caused in some by chronic cystitis and in others by incomplete emptying of the bladder. In the presence of large cystocele, patients frequently complain that they have difficulty in micturition and that the more they strain, the more difficult it becomes to pass urine. The explanation of this symptom is that when the intra-abdominal pressure is raised during straining, the urine is pushed down into the cystocele below the level of internal meatus. Patients often mention that they are able to pass urine by repositioning the prolapse in vagina with the help of a finger. This is termed as splinting. Stress urinary incontinence occurs when the neck of the bladder and internal urinary meatus descend below the level of pelvic muscle floor. Urinary symptoms develop when puborectal fascia, pubocervical fascia is damaged and breaks occur at a level 3 support. Coital difficulties with third degree uterine prolapse and procedure are obvious. Investigations. They should be carefully examined because the treatment is based on the physical signs observed. Although most patients are examined in supine position, examination in squatting position or standing position will help to assess the degree of prolapse. During examination, she is made to cough, strain, and the nature and degree of prolapse is noted. Examination is done with a partially full bladder when there are symptoms of stress incontinence. Vulva is examined for the evidence of any perineal laceration. Speculum examination determines the degree of uterine descent, associated prolapse of anterior and posterior vaginal wall. Cervical cytology may be obtained, but it is important to remember that in a third degree uterine prolapse in precedentia, satisfactory smear may not be obtained. The lab investigation include hemogram, urine examination, urine culture sensitivity, blood urea, blood sugar, X-ray of the chest, ECG and other investigations necessary before major gynecological surgeries. IVP is rarely indicated and may reveal ureteric obstruction in major degree of prolapse. Ultrasound and MRI may help in localizing defects in supporting differential diagnosis. Vulval cyst and Gartner cysts can be easily differentiated from prolapse. The cyst of anterior vaginal wall, usually tense with well-defined margins, cannot be reduced on pressure. Urethral diverticula are rare, always small, and are situated low down in the anterior vaginal wall. Urethroscopy helps in the diagnosis. Congenital elongation of cervix can be differentiated from prolapse as it is the vaginal portion of the cervix that is elongated and there is no accompanying vaginal wall prolapse. The fornices are deep. Cervical fibroid polyps can be easily identified as the cervix is high up and the rim of the cervix can be felt above the pedicle of the cervical polyp. Chronic inversion of uterus can be recognized because the cervix is further up and the uterus cannot be defined. The uterine sound will confirm the diagnosis. Ultrasound and laparoscopy will identify the fundal depression with the absence of uterus fundus in the pelvis. In rare cases, the patient may complain of vaginal prolapse, but in fact, a rectorectal prolapse is evident. Prevention of prolapse. Antenatal physiotherapy, relaxation exercises, and due attention to weight gain and anemia are important. Proper supervision and management of second stage of labor. Episiotomy, if indicated in primi gravida breech delivery, instrumental delivery should be performed. Recently, however, the usefulness and the role of episiotomy in prolapse has been questioned. Forceps delivery when to should be resorted only if there is a delay in second stage of labor. Perineal tear must be immediately identified and repaired after delivery. Postnatal exercises, physiotherapy are beneficial. Early ambulation in postpartum period. Adequate rest for the first 6 weeks after the delivery and availability of home help for heavy domestic duties, and a reasonable gap between the two pregnancies. Treatment. Surgery remains the main mode of treatment for prolapse uterus. However, before resorting to any surgical treatment, the most important decision is the appropriate treatment for the prolapse in a young woman following childbirth. Conservative measures should be advised following delivery for the initial 4 to 6 months. Surgery is advised in women older than 40 years. Pessary treatment of prolapse. The ring pessary for prolapse is nearly a thing of the past in elderly women and very young women desirous of further childbearing. It causes the limitations of pessary treatment are it causes vaginitis, ulcerations in the vagina. Pessary needs to be changed every 3 months. Wearing of pessary is not comfortable to some women and may cause dyspareunia. If the vaginal orifice is patulous, the pessary often gets expelled, especially in squatting position during defecation or urination. A forgotten pessary may be the cause of ulcers in vagina and in rare cases can produce carcinoma of vagina and a vesicovaginal fistula. Ring pessary is not helpful for symptom of stress urinary incontinence. Current use of pessary are limited to a young woman who wants to have subsequent children, prolapse during early pregnancy, purpurum, temporary use while treating infection and decubitus ulcer, who is a woman unfit for surgery, in a woman who declines surgery. Operative treatment of prolapse. Surgery remains the main treatment. The aims of the surgery are to relieve the symptoms, to restore the anatomy, to restore the sexual function, and to prevent the recurrence. Preoperative preparation. Estrogen cream applied locally for senile vaginitis will help in improving the condition of vaginal mucosa, but should be stopped few days before the surgery. The patient should receive a course of urinary antibiotics if urinary tract infection is present. Decubitus ulcer may heal by daily insertion of vaginal tampon soaked in acreflavin or betadine solution for 2 weeks. Surgery. Surgery for the anterior vaginal wall prolapse is anterior corporaphy. For the posterior vaginal wall prolapse is posterior corporaphy. Surgery for prolapse of uterus, Manchester operation in the young woman, vaginal hysterectomy in women older than 40 years, surgical operation for nulliparous prolapse is sling operation, surgical procedure for vault prolapse, abdominal or vaginal surgical procedure. Management of genital prolapse based on the age. For nulliparous, abdominal sling operation are preferred. In pregnancy, ring pessary is preferred up to 16 weeks. Postnatal, ring pessary and pelvic floor exercises for 3 to 6 months are done. Surgery is done only if required afterwards. Young women less than 40 years, conservative vaginal surgery, fertility sparing surgery is done. Rectocele, cystocele repair, Manchester operation, sling operation. Women older than 40 years and multipara, vaginal hysterectomy and pelvic floor repair is done. Anterior colporrhaphy. Anterior colporrhaphy operation is performed to repair the cystocele and cystourethrocoele. Traction is given on the cervix to expose the anterior vaginal wall. An incision T-shaped, inverted T-shaped is made in the anterior vaginal wall, starting with transverse incision and in the bladder sulcus. Through its midpoint, a vertical incision is extended up to the urethral opening. First, an transverse incision, and from the midline, a vertical incision is given upwards. The overlying vesicovaginal fascia is tightened and the excess vaginal wall is excised to correct the laxity. Then the vaginal wall is sutured. In women suffering from stress incontinence, in addition, a curly suture is placed in the region of the neck to bladder neck to correct the stress urinary incontinence. Posterior colporrhaphy and colpoperineorrhaphy. Posterior colporrhaphy is an operation done to correct the rectocele and repair a deficient perineum. The lax vagina over the rectocele is excised and the rectovaginal fascia repaired after reducing the rectocele. The approximation of medial fibers of the levator ani helps to restore the caliber of the hiatus urogenitalis, restore the perineal body, provide an adequate perineum, separating the hiatus urogenitalis from the anal canal. It is commonly combined with an anterior colporrhaphy or a vaginal hysterectomy to avoid recurrences and to reinforce the weak supportive fascia. Some use mesh in the facial layer. However, dyspareunia, erosion of the mesh, or infection requiring its removal, sinus formation are the disadvantages. Fothergill's operation or Manchester operation. In this operation, the surgeon combines an anterior colporrhaphy with amputation of the cervix. The cut ends of the Meckenrod ligament are sutured in front of the cervix, and the raw area on the amputated cervix is covered with vaginal mucosa. A special technique of covering cervix with the vaginal mucosa has been described and is called Sturmdorf sutures. It is followed up by colpoperineorrhaphy. The operation preserves uterus for menstrual and childbearing functions. However, subsequent pregnancies may be associated with mid-trimester abortion or a preterm delivery. In some cases, there is failure of dilatation of cervix during the labor requiring a caesarean section. It is suitable for women younger than 40 years who are desirous of retaining their menstruation and reproductive functions. In younger women, the procedure can be combined with tuber sterilization if the family is complete. Shirodkar procedure. In this procedure, amputation of the cervix is avoided. Anterior colporrhaphy is performed as usual. Attachment of Meccan rods to the cervix on each side is exposed. The vaginal incision is then extended posteriorly around the cervix. The pouch of Douglas is open. Uterosacral ligaments are identified, divided close to the cervix. Stumps of these ligaments are crossed and stitched together in front of the cervix. A tight closure of peritoneum of pouch of Douglas is carried out. As the cervix is not amputated, subsequent pregnancy complications are avoided. The rest of the operation is similar to Fothergill's. Other conservative surgery are vaginal sacrospinous hysteropexy, abdominal or laparoscopic sacrohysteropexy. These can be combined with cystocele or rectocele repair. The advantages are vaginal length is maintained, cervix is preserved for sexual function. Vaginal hysterectomy with pelvic floor repair. Vaginal hysterectomy with pelvic floor repair is suitable for women older than 40 years, those who have completed their families, no longer keen on retaining their childbearing and menstrual function. The steps of vaginal hysterectomy are: a circular incision is made over the cervix below the bladder sulcus, and the vaginal mucosa dissected off the cervix all around. The pouch of Douglas is identified posteriorly. Peritoneum is incised and opened. The bladder is now pushed upwards until the vesico-vaginal peritoneum is visible and is similarly incised. The uterus is now free in the front and the behind. The pedicles containing Meccan rods, uterosacral ligaments are clamped on either side, close to the cervix. Cut on the uterine side, and the pedicles are transfixed. Next, the uterine vessels are identified, clamped, cut, and ligated. The upper portion of the broad ligament holding the uterus contains round ovarian and the fallopian tube. These are similarly dealt with on both sides and the uterus is removed. The peritoneal cavity is closed with a purse string suture using chromic catgut 0. Anterior colporrhaphy, posterior colpoperineorrhaphy are performed as required. The vagina is packed with betadine or acrifavine pack for 24 hours. A Foley catheter left in place for continuous drainage of urine for 48 hours. In case Kelly stitches were placed for SUI, the catheter is kept for 5 to 7 days. Complications of the surgery are hemorrhage, sepsis, urinary tract infection, complication related to anesthesia, subsequent vault prolapse, dyspareunia due to narrow or short vagina. Alternative methods of tying pedicles during surgery are ligature. Ligature vessel sealing system is lately used to secure pedicles in vaginal hysterectomy. Vaginal hysterectomy is contraindicated if uterus is very bulky, more than 12 to 14 weeks. Uterus is fixed by abdominal adhesions and inflammation, or if the woman had previous abdominal surgery like C-section. Other pelvic pathology existence like endometriosis and ovarian tumors. In such cases, proper laparotomy is indicated. Leafold's repair. Leafold's repair is reserved for very elderly menopausal women unfit for the major surgery. In this procedure, anterior and posterior vaginal walls are approximated below the level of cervix. Before the procedure, a pap smear pelvic sonography should be obtained to exclude possible pelvic pathology. The procedure is performed under sedation, local anesthesia, or epidural. The flaps of the vagina from the anterior and posterior vaginal wall are excised, raw area supposed with catgut sutures, thus wide area of adhesion is created in the midline which prevents the uterus from prolapsing. The small tunnels on either side permitting drainage of the discharge. This operation limits marital function, hence it should not be advised in women who are leading an active sexual life. Some women may develop stress incontinence. Other contraindications are menstruating women and women with diseased cervix and uterus. Abdomen sling operations have been described for young women suffering from nulliparous prolapse or the second or third degree uterine prolapse who are desirous of retaining their childbearing and menstrual function. They include abdominal wall cervicopexy. The operation entails opening of the abdominal wall through low trans or suprapubic incision deep and down up to the rectus sheath. By means of transverse incision made in the rectus sheath, two musculofacial slings are elevated from the midline outward laterally up to the lateral border of the rectus abdominis muscles on either side. The peritoneum is opened in the midline, uterus brought up into the view. The uterovesical fold is incised, the bladder mobilized from the front of the uterine isthmus. The medial ends of the facial sling are now directed retroperitoneally between the two leaves of the broad ligaments up to the space created in the front of the isthmus. The slings are pulled through and anchored there with a stout non-absorbable ligatures after ensuring that the adequate correction of the position of the uterus in the pelvis. The uterovesical fold is next sutured, followed by closure of abdomen in layers. Presently, the surgeon uses 12-inch long mercilin or nylon tape to provide new artificial supports for the uterus. The tape is fixed at its midpoint to the uterine isthmus anteriorly and its lateral edges brought out retroperitoneally between the two leaves of the broad ligament so as to emerge at the lateral border of the rectus abdominis muscle on either side. The ends of the tape are now fixed to the aponeurosis of the external oblique muscle of the abdominal wall, either by weaving it through the aponeurosis on either side from the medial to the lateral side, or by fixing it to the undersurface of the aponeurosis with interrupted non-absorbable suture. Shirodkar abdominal sling operation for uterine prolapse. This operation was designed to meet special needs of case of nulliparous prolapse having inherently weak supports. It is technically a difficult operation to perform. Using mercilin tape, the cervix is fixed to the lumbosacral fascia by passing the tape extraperitoneally. Kanna sling operation. In this operation, the mercilin tape is fixed to the isthmus posteriorly, two free ends brought out retroperitoneally emerge out at the lateral margin of the rectus abdominis muscle on either side. They are anchored to anterior superior iliac spine on the either side. Enterocele. Whenever enterocele is encountered during the prolapse operation, it should be repaired. Vault prolapse. Vault prolapse is a delayed complication of abdominal and vaginal hysterectomy. It results because of poor attention paid to anchoring the support structures to the apex of vagina. It also results from failure to identify and repair an enterocele during hysterectomy. A technical error in previous surgery, age, estrogen deficiency in menopausal women, parity, obesity, and chronic cough may contribute to the existence. Degrees of vault prolapse. In the first degree, vaginal apex is visible at the introitus. In second degree, the vault protrudes through the introitus. In third degree, the entire vagina is outside the introitus. Vault prolapse is often associated with cystocele and enterocele. Prevention. Enterocele should be recognized and repaired during the primary surgery. Attachment of uterosacral and cardinal ligaments to the vaginal vault during the hysterectomy reduces the incidence of vault prolapse. Treatment. Right transvaginal sacrospinous colpopexy in obese and elderly women not fit for abdominal surgery was described. McCulled caldoplasty comprises fixing the uterosacral and Mackenrod ligament to the vaginal vault and peritoneum of pouch of Douglas. Ureteric obstruction and kinking are reported in 10% cases. Vaginal route is safer for elderly women. Complications of the surgery include hemorrhage, sepsis, trauma to the bladder, urethra, or rectum, urinary infection, thromboembolism. Late sequelae include narrow scarred vagina causing dyspareunia, granulation tissue. Vault prolapse in young women is treated by abdominal sling surgery, sacropexy, colpopexy, laparoscopy, colpopexy. In old women, vaginal sling surgery like right transvaginal sacrospinous colpoplexy, transabdominal sacropexy, colpoclysis, Leafold's operation, abdominoperineal surgery, ring pessary, posterior intravaginal slingoplasty are done. Vaginal sacrospinous colpoplexy. Following opening of the posterior vaginal wall vertically, a window space is created between the vagina and the rectum towards the right sacrospinous ligament. A synthetic sling such as mercilin mesh fixes the vault to the sacrospinous ligament with a Mia hook 2 cm away from the ischial spine using a non-absorbable suture. During surgery, care is taken not to injure the rectum, pudendal vessels and nerves at the ischial spine, sciatic nerve and sacral plexus which lie above the ligament. 90% success have been reported. Buttocks pain following this operation resolves gradually. Abdominal sacrocolpopexy. In this procedure, the vault is fixed to the sacral promontory by interposing a mesh between the apex of vagina and sacral promontory. The mesh is covered with the pelvic peritoneum to make it retroperitoneal. The same procedure can also be done laparoscopically. Colpoclysis as a treatment for vault prolapse is used only in selected very old women unfit for major surgical procedure. Leafold's operation is another alternative. It is a kind of partial colpoclysis. Abdominal perineal surgery described is a difficult surgery required in complicated cases, especially if rectal prolapse is present. Ring pessary is recommended in women not fit for surgery. Anterior and posterior colporrhaphy may be required for cystocele and rectocele in addition. Postoperative care is important and include parenteral fluid until bowel sounds return. Early oral fluids are now advocated. Antibiotic sedation, metronidazole for 24 hours. Indwelling catheter for 48 hours. Vaginal pack for 24 hours and early ambulation.